is welcome everybody to the second in a series of WebExes that is coordinated through Healthcare Improvement Scotland, specifically the Living Well in Communities team who coordinate the Neighbourhood Care Programme. My name is Alec Murray, I'm the Associate Improvement Advisor, and this is Turner.
Hi, I'm the Project Officer for the Neighbourhood Care team.
And we're delighted that the Buurtzorg Britain and Ireland are supporting us to deliver these WebExes. We've had one already back in November, and this WebEx number 2 is the second in a series of 6. And the topic is the Buurtzorg Onion Model, co-creating care plans with clients, supporting independent quality of life at home, and navigating the health and social care system. So it's all from me, because you're not here to hear me speak, you're here to hear Brendan from Buurtzorg Britain and Ireland, and we're delighted to have Madeline, a Buurtzorg nurse from the Netherlands, join our call as well. So thank you very much for joining us, Madeline. Sarah's going to give you a couple of WebEx tips. We'd encourage you to chat into the chat box, so maybe as a test, maybe to say what's your name and where you're from, that would be great. And over to you, Sarah, to give us some tips.
Hi everyone. Just to let you know, this session will be recorded and we will share the recording afterwards. Just during the discussions, it would be helpful if you could mute your phone lines. I know the room we're in, there's a lot of background noise next door, so we'll mute our lines. And if you've got any questions, you can raise your hand, or if you click on the chat box, you can ask some questions and we can come to them at the end.
So we'll collate the questions while Brendan and Madeline are chatting. The chat should happen for 15 or 20 minutes, I think, Brendan, you have planned. Then we'll open the line again for any questions from the audience. It's over to you, Brendan and Madeline. Sarah will just pass you the ball, which will give you control of the presentation.
Yeah, you will start, Brendan.
Yeah.
Yeah.
So, welcome everybody, thank you for joining. It's a great pleasure for us to be doing this WebEx series in conjunction with Healthcare Improvement Scotland. And this second one is going to be going into some detail, as much detail as we can, about really the very fundamental basis of the Buurtzorg model, which is the relationship between the professional and the person that she's supporting and the people around them. And this is represented in Buurtzorg by the onion model here. I'm so delighted to be joined today by Madeline van Tilburg. She's a very experienced Buurtzorg nurse who also works as part of the Buurtzorg international team. And she has been in Scotland once or twice, I think, up into the Highlands and the borders.
6 or 7 times, I think,
6
already.
or 7 times to work with us
everywhere
on the program that we've been doing. So, Madeline, let's start just by asking you just a couple of questions about yourself, your background, and also tell us where you are today, because we see the top of the Buurtzorg logo there, but we're not quite sure where you are. So tell us the details.
Welcome, everybody. I'm at the Buurtzorg team office. Actually, I'm in the storage room because this is the only quiet place I could find, and I'm sitting on a commode, so that's quite an interesting, so I feel at home. And I got a sweater from a Buurtzorg nurse here, so I'm all set for this meeting. Yeah, I'm in the team office near Amsterdam, in Diemen, so that's the place. Yeah, so that's where I am.
Thank you, Madeline. A little bit about your own background.
Yeah. I'm a community nurse. I started working for Buurtzorg now already, I think, almost 8 years ago. I worked in a team based near The Hague, a small village. I worked in a team for 6-7 years, and now the last year I'm more and more involved in international work. So we got a lot of requests from everywhere, and we try to facilitate and work together with all other organizations and nurses from all different countries. So that's what we are doing now. Actually, we're together with our international team right now. So
thanks.
Yeah,
Thanks.
But I have a lot of experience working in a Buurtzorg team.
And that's the experience we're going to tap into today.
Yeah.
When I've heard you give presentations, Madeline, I've often heard you say first coffee, then care. What do you mean by that?
Yeah, we drink a lot of coffee in the Netherlands. We like coffee, but it's not about the coffee, but it's more that an expression to say, okay, let's first sit together and see what's really needed in a client situation, and then start caring, instead of, okay, I have my list of tasks I have to do, I start working immediately with my client. No, of course, it has to be when there's an acute situation, we don't start first with coffee and then, but in general, we first, when we do an initial interview, when the first client contact, we first sit together over coffee or whatever. And then we talk about our vision of Buurtzorg, and we look closely, okay, what can we support, on what part can we support our clients. So first, step a little bit back, first try to work on a relationship and then start caring. So that's, that's a little bit a different approach. And that's what we mean by first coffee and then care.
And when you're building that relationship with a new client, what kind of questions do you ask her, Madeline?
Yeah, it's not always that formal. Of course, we have a kind of, so every team has a kind of a checklist what you have to ask in this first interview. But while working with your client, you build up a new relation. You see maybe pictures from family members, or you see something in the house, or you talk about things, and so slowly you learn more and more about your client. So that's not that you have to ask those questions, but it's more, so talking with each other and try to build up a trustful relation with each other, and then you learn more. That's more the first conversation, but of course the medical history is important, the disease is important, so there are things important, but also we focus also on the other sides of a client, not only on the medical part.
Okay.
Is it disturbing the noise, or is it okay? I hear a door.
I think we can live with it, Madeline.
Okay.
What about, we often meet nurses in this country who say they really would, particularly nurses working in the community, they really want to support their patient or client to manage their own care more effectively, but sometimes they find that very difficult for whatever reason. Do you ever find that I know it's a very important part of the Buurtzorg approach that you are supporting clients to be self-managing their care. Can you tell us a bit more about that? And do you also, even in the Netherlands, sometimes have difficulty in persuading clients to cooperate with you more in playing their part in the self-management of care?
Yeah, we have 80,000 clients every year, so we have a lot of variety in clients. Most ideal, of course, are the clients who really want to be up and running as soon as possible. But also there's a big group who, have this vision. Okay, you are the nurse, I'm the patient. You have to take care of me. And especially in the beginning of Buurtzorg being there, this was more and more common. They were really used to the nurse taking over and arrange everything for them. But now also in the Dutch context, also in the Dutch healthcare, it's more and more that you together look, okay, what's the best option? So we move away from more the classical patient-nurse relation to, okay, what can we do together? But I must say, in some cases, with some clients, this is rather a tough journey. They want us to do all, because I'm old, you're the nurse, so you have to do it all. But then again, this building up this trust and working on this together and explaining about our vision, you try to persuade them to be more self-managed. But sometimes you really have to be creative to do things, because now more and more you see that our visit is not only because we are providing care, but also that they see us as a solution for their loneliness. So that's where we have to come up. Okay, how can we, look, then you see it's not the nursing part that's the problem, but you see other options, other problems, and then you have to come up with other solutions. So it's an ongoing, and sometimes but you need to start slowly, small steps, and build up confidence for them that they can do it alone, and also for their families, because most of the time the daughters and the sons and the family, they find it quite reassuring. They feel secure because we are there. And I can imagine, but then it also starts a conversation, okay, what's really necessary to work? And sometimes it takes a while before you reach the state of self-managed clients, and sometimes it's already there in the beginning because of the motivation of the client.
Okay,
so we have, a big variety.
So it's a bit like in Britain, of course.
Yeah, I think we have similar situations,
And but when you've made an assessment and a care plan with the client, and you've started working with the client to deliver that care plan, how do you evaluate how that plan's going? How do you evaluate the outcomes?
We always make the care plan together with our clients, so they agree on what we are doing. And now also part of our IT system is more and more that the client is the owner of his own file, so he can see and he can access other into his file. So he is. It's really a thing we want to do together, especially when you want to work on this client self-management. It's really helpful that they feel part of it. And sorry, what was your question again?
How do you evaluate the outcomes?
Oh, how do we evaluate? So we create a plan together, and also part of the system is that we can set when we want to evaluate. We have the formal, what we call the formal evaluation. We set them, depending on the situation, we set them within a month or 2 months or 6 months. When it's a chronic situation, then it can be 6 months. But evaluation is also done in a more informal way by sitting together with this coffee. Just 10 minutes can add so much can give you so much information about the situation. So there's a lot of evaluation in between, so that you just ask, okay, how are you doing? How are we doing? What do you want? What do you need? But the formal ones are part of our care plan.
Okay, thank you very much, Madeleine. We're going to move on now and look at the next ring of the, or the first ring around the core, which is the person needing support. Let's look at the next ring, which is the informal networks. First of all, in the onion model graphic there, you see the term informal networks. What do you mean by that?
The informal network, that's what we see as everyone who is around the client, not from from the profession side, but more from the circle around clients. It can be family, it can be a partner, a husband, wife, can be children, can be neighbors, can be friends, can be whatever. So that's what we call the informal network around the client.
And how do you work with them? How do you involve them in your care for the person that you're caring for? What kind of involvement do they have?
That also differs from every client. With some clients, they have a huge network, and you'll know their whole history in 1 hour. They are really open, and everyone is there. And with others, that are the more ones where you have to work, be more creative. They don't have a network, and most of the time that has a reason. So then you try to create one. And there can be, I had one situation, there was a client of ours, she needed wound care. and I discovered that, she didn't have any network. She used to be a nurse. She was working and she was living together with her sister. Then the sister died and she retired from her work, and that was her network. And then all of a sudden there was no one there. And then the wound was healed, but I saw there was a need for some company. And then we also had another client, and she did a lot of volunteer work. And then I connected them together. So that's one idea to create a network. And you can't expect with someone with a very small network, all of a sudden they have a huge bunch of friends and everyone. So, but starting with very small steps. So this was, now they meet for many years already. Every week they meet, and then from this meeting there will be another thing, and now she's more part of things. So most of the time when there's no network, you have to take really, really slow steps and to create someone around the client. Yeah.
It sounds like you need to be pretty patient.
Patient and creative and think outside the box, and there's no standard, so you really have to see every situation as a unique one. So to approach it every time again, okay, what can I do here, and what's really necessary? What's really the question here? Yep.
Do you sometimes involve local voluntary organisations as well?
Yeah. The next slide, that's about a formal network. I will say a little bit about it already in this
Okay, so we'll get
context.
on to that in a minute or two then.
Yeah.
One last thing on this one. Do you, I suppose, just like some clients don't really want to or aren't very willing to self-manage their care, some clients perhaps aren't very willing to involve their family members or their neighbours. Do you come across that problem?
Yeah, it can also be a cultural issue, because we have a lot of clients from Suriname in the area where I work, and there it's not allowed in their culture that the son will take care of the mother. So then we have to also, we can't just say, yeah, but this is our vision, so that's what we want to do. So every time you work around their context as well. And if there's no one, the Buurtzorg team will be there. But always try to keep this in mind. Always try to find ways to create or start creating a network.
Thanks, Madelon. Let's move on to the next ring of the there we go. Sorry, I've pushed on too far there. Yeah, to the next ring, which is the team and the clients. We're not going to talk a lot about the team today, because that's going to be the subject of a future webinar in this series. But how many of each team typically would be seeing a particular client? Would it be all the team, or just one, or something in between?
Yeah, it can be all different things. Just to say a little bit about a team to place this in context. A team is around 8 to 12 persons. Something later on you might explain more about it. And as a team, we take care of a group of clients. But the reason why Buurtzorg started, that the clients were facing so many different caregivers, we try to have as many different faces in a client situation, but it depends on their care need. So if they have 4 care moments a day, they will see the whole team, but that's the maximum of 12. But some only have visits once a week or once every 2 weeks, when it's more about talking, or they're still coping with the situation, then they will see 1 or 2 nurses. But for us it's important, because we also want to share and how do you say it, when we want to talk about our clients with our colleagues, it's important that other colleagues will see the clients as well, also for the continuity when I'm on holiday or sick, then they also are related already to the others. Sorry.
And I suppose that sometimes you visit a client that, let's say, you don't normally visit, and you might find that you don't. That if you find that your approach to supporting that client is a little bit different from one of your colleagues' approach, how do you handle that disagreement if there is one?
As I said, part of our team meetings is that we talk about our clients. Part of the working in a self-organized team is that you reflect on your own actions. That's part of your profession, but also we reflect on team level. So we put on a client as a topic of our team meeting, and that we talk about who's doing what and why are you doing it like this and why I am doing it like that. So it's an open. We try to create an open culture that we talk about those things, because often you hear from your clients that they are talking, oh, your colleague is doing it in a totally different way, and then for me it's an eye-opener. Oh, wait a minute, then I will talk to my colleague. Okay, why are we doing it in a different way? So that's part of our culture, that we talk about those things. Yeah, to get the best. The best output for your clients.
Thank you very much, Madeleine. And of course, in the first of these series of webinars, we outlined the Buurtzorg model in general and talked about the teams are local neighbourhood teams, self-organised, with 8 to 12 members in them, and we'll go into more detail in that in the future webinar that looks at that in detail. Let's go on now to the last ring, the outer ring of the onion model. And how the Buurtzorg team works with the formal networks to support the overall care of the client. Can you tell us a bit more about that, please, Madeleine?
Yeah, what we mean by formal networks, as I tried to explain, that's all the stakeholders in your area. It can be hospitals, general practitioners, occupational therapists, physiotherapists, dietitians, you name it, but also a voluntary organization, churches. So when a Buurtzorg team starts, it's always the initiative of nurses who want to start a team. Then it's up to the team to make a social map of your community. So we work in a community, and so that we reach out proactively to all the different stakeholders in our area. And we are the Buurtzorg team. We really want to work together. Okay, how can we do this, and how can we maintain this working together? So this is what we mean by the formal network. And the Buurtzorg team is only combined of nurses and nurse assistants, but if needed, we pull in other professionals in specific client situations.
So does that mean you're sort of serving as a sort of care manager as well as a care provider for your clients? You're helping them to get access to the different kinds of professional support they need when they need it.
Yeah, for example, when you see loneliness is more an issue, and then I know they're at the community house, they have a coffee morning, and then I can say to my client, okay, they have this, and it looks like maybe this is something for you to go to. And actually, sometimes I go together with my client because they find it a very big step to go there on their own, just all strange people, and then we go together for the first time. So, but then it's up to the team that they know about this, about what's going on in their community.
Okay.
It can be, I won't call it the manager, it's more, I think, like a coordinator, that we try to show them, okay, this and this and this is all available. If you want to go there, we can find ways for you to attend those things or those services or whatever needed. Yep.
Madeleine, thank you very much for that. I think we've got about 5 minutes to look at any questions that have come in.
Already 30 minutes gone.
I'm not seeing any questions.
No.
Should I be seeing any, Sarah?
I saw one at the beginning, but now I can't see it anymore.
Yep, Sarah's been keeping a note of them. So, I mean, if anybody saw someone has raised their hand, Sarah will maybe ask the questions on your behalf, or if you want to jump in on the line now, feel free.
Hello, it's Sue here. Could I ask a question?
Hi, Sue. Yes, go ahead.
Yeah, I was just, as an ex-community worker, I was just very interested in the idea of nurses producing a social map of the area. Is that something that all nurses, when they join the team, do individually, or does one person do a map and share it with others, or do other people have responsibility for updating it? Because obviously these things go out of date and, you know, things change, and just wonder how that's managed.
Yeah, it's an organically thing. So when you start working, you have the more formal ones like GPs and the pharmacies. And,
yes.
But it's a growing and it's a living thing. And one of the of our team members is keeping it alive and updated. So maybe there's a hairdresser who comes to clients' houses, and we write down her name. I can understand if you don't keep it alive, then it doesn't make sense. So in our team we appointed one who is the one who will make sure that's updated, and but it's the whole team responsibility to
right.
To put input if you hear something, and it's also on our IT system. You can put it in the IT system as well.
Right.
So you can see, okay, this is all things important for the team. I can see immediately who are around me.
Yes, yeah. And presumably if a client had a bad experience of going along to a group or a club, the nurse would feed that back to the team meeting and saying, you know, just to let people know that this is that person's experience.
Yeah, it could be a personal one, but if it's a really severe thing, then it's also, we got feedback. So, example, for this hairdresser, she's really rude, or then we don't recommend it to the others. Their feedback is very important for us.
Yeah, that's great. Thank you.
Yeah.
Got another question in the chat box. Working in teams with more responsibilities must provide greater job satisfaction. Is there ever any resistance to work with more responsibilities? If so, how is this addressed?
Resistance from...
Well, I'm expecting Sarah, there's other questions too, which will hopefully jump in. This is one of mine, Madeline, was I think that when people work with more responsibilities, they must get a tremendous amount of job satisfaction to help both in a social care way and a health care way. But I wonder, is there ever anybody that doesn't want to work in that way, that they think it's maybe too much responsibility, or they want to work in the old way, or how do teams deal with resistance really between them? How do they agree on change?
I always say Buurtzorg is not for everyone. It's what you are saying is correct. That it's more than just taking care of your clients. You have your own enterprise to run. It really feels like your own shop. And in our team, we had one nurse who was only interested in taking care of the clients and not so much in all the other things aligned to working in a self-organized team. And then, we talked about it because, we have to share the caseload, also not only with the clients, but also on the other tasks. And at the end, she decided that the Buurtzorg way of working was not for her. So I always say it's not for everyone, but that's okay. Then there are other places where you can work. And later on, she told me that now she felt more at ease in her new way of working. So that's fine, I think.
Okay, thanks, Madeline.
Yeah.
We're just about to get chucked out of room, but we've got one more question, and that's how many clients are in a typical caseload?
Ideally, because we have 965 teams, so they all are working slightly different. Ideally, a team is between 8 and 12, and a caseload around 50, 60, depending on their care needs. But that's roughly, if I can name an average, that's what a Buurtzorg team looks like.
So a Buurtzorg team would be looking after a caseload of about 50 or 60. It's also important to remember that the 8 or 12 members of a Buurtzorg team are largely part-time, So you're probably talking about something like 6 to 9 full-time equivalents for that level of caseload.
I think the exact average is 6.7 full-time equivalent. So when we talk about 8 to 12 in a team, we talk about people. But most of them, what you're saying is correct, Brendan, are working part-time. So I think the average hours is 24 or 28 hours. Yep.
Which brings us to the last question, which is, given that you've got that number in the team, how do you provide 24/7 care, or do you provide 24/7 care?
Yeah, we are available 24/7, 7 days a week, but we don't provide so much care at night, but we have an on-call system. So if needed, we go out at night. If there is a need for night care or 20-hour care, then we have another part of Buurtzorg who can provide this care. But the teams, they have a system in place that they are available by phone 24/7.
Thank you very much, Madeline. Thank you so much for joining us.
Thank you.
I will end up talking about the team, which is a good segue into the next of the webinars, which will be looking in much more detail at how the team itself functions.
Okay.
And there you can see a list of the next round of seminars. But how do self-managed teams work? And that one will take place on the 11th of January. Maybe we'll ask you to come back for that, Madeline.
I would love to, but unfortunately I'm on holiday, so I can't make it.
One of your colleagues will join us, I hope. But thank you very much for today.
Yes. Yeah, thank you very much. Yeah. Okay, thank you. Bye-bye.
Everybody for joining. Thank you very much for your time, Brendan and Madeline as well. If there is any questions, because we realise that these are quite short, half an hour webinars, if you just send them into the Living Well in Communities team, and we'll collate them, send them to Brendan and Madeline, and we'll send the responses out to everybody with the recording of this WebEx as well. But thank you very much once again, and we'll see you next time on the 11th of January.